Hi, this is Roger Green, host of the Surfing the Mesh Tsunami podcast. This week, we're offering 5 conversations from episode 20, our review of drug development stories from the EASL Congress 2024 with Jörn Schattenberg, Naim Alkhouri, and Mazen Noureddin, plus from the vault, one of our wrap-up conversations from the EASL Congress 2023. This first conversation centers largely on some of the Resmetirom research presented at the EASL Congress, with an important digression to discuss different modes of analysis. Mazen begins the main conversation by sharing a paper he presented on Stephen's behalf, looking at dose response with Resmetirom. The analysis indicated that PDFF and histology improvements at the 100 milligram dose were greater than at the 80 milligram dose. Jörn notes that while that was important, he felt the most important element in the study might be the demonstration of effect lasting at least 36 months. Mazen, who had originally described that as the most important slide in the study, agreed. As an aside, Mazen also mentions the study from Samer Gawrieh demonstrating that dropping liver stiffness to less than 10 kilopascals correlates with a 75% reduction in clinical liver events. He reported that Resmetirom was a bit higher than 10 in year 1, but dropped below that for patients continuing to years 2 and 3. At this point, Naim shifted focus slightly to compare intent to treat, modified intent to treat, and completer analysis. His point? Intent to treat, which rates all non-completers as failures, will produce lower rates of response than a completer or modified intent to treat analysis, which either eliminates the non-completers or assigns placebo-level response to them. He notes this will be important for other studies that we will discuss during this episode. During the episode, all of us kept comparing the negativity and virtual despondence of the 2019 to 2020 period described as the graveyard with what's described as today's gift shop of multiple modes of action, demonstrating clearly positive results. It's an exciting time for the field and for the patients. As I edited, I found myself thinking of Stephen's goal to put a big fat dent in fatty liver disease. We all can use this episode to gauge the size of Stephen's dent, and frankly, it's pretty damn big.
Mazen Noureddin.
Since you mentioned Resmetirom, I did this presentation on behalf of Madrigal, and Stephen was supposed to present this, but it is actually interesting presentation that we had. I don't have to tell people now that Resmetirom was approved in March and yada yada. But the key thing is, if you remember with the approval, there was 2 things, or like a major thing with the dose, which is people more, if you want to remember it, more than 100 kilograms, they get 100 milligram, and less than 100 kilogram, they get 80 milligram. And the study was not stratified based on that. The study was stratified both in fibrosis and diabetes. So the people, regardless of their weight, more than 100 kilogram or less, they got both doses. Then after the fact, either the sponsor or the regulators did analysis and they recommended the right dose for people. I'm not going to go really deep into it so I don't spend time and leave it for other, because I'm excited also about other products in addition to Resmetirom. But in this analysis, what we did, we looked at 2 things, PDF improvement and the histology and many other things, target engagement and stuff like that. And we looked at it by weight, right? So more than 100 kilogram, less than 100 kilogram, and BMI more than 35. And BMI less than 35. But long story short, if you are more than 100 kilogram, what we notice is, for instance, the PDFF, the histology response was a bit less. And I'll give you an example. More than 100 kilogram PDFF response more than 30% was 73% of people. And more than 100 kilogram, I'm just going to talk about more than 100 kilogram versus 57% if you got the 80 milligram. So if you got 100 milligram, if you're high weight, 73%. If you got the 80 milligram, 57%. Similar again in the 100 kilogram, if you got the 100 milligram for histology, fibrosis improvement was 33%. And if you got the 80 milligram and the high weight, 23%. And the NASH resolution was 36% on the 100 milligram and 27% on the 80 milligram. So I think the take-home message is that dosing was important. I do wonder if the trial, if it's kind of redone, for instance, and I'm not saying it should be redone, if it's redone based on weight, I wonder if the NASH resolution and fibrosis improvement will be even better from what they published, which is plausible, right, based on this observation. I mean, it's like analysis after fact, optimistic. I don't want to overcall it on anything like this. But one thing that we can think of, if you, for instance, do histology in real world and we're not requesting that and no one is doing it, I think it might be better than what was even seen in the New England Journal paper. So that was a nice spin there, encouraging and going the right direction, that we, in real world life, we might might even see more response, although the real world life is its own analysis and its own rules.
Jörn Schattenberg.
The other thing I took from your presentation, Mazen, I think you said that was the most important slide for you, was the VCTE over up to, I believe it was 36 months, decline placebo versus the two doses, because really the NITs are showing a direction of response there, right?
Yeah, the Matt Damien of NASH, again, like he's spot on and he's like always smart. So yes, I forgot about the most important slides. Like I was a bit surprised to start hearing about the futility rule, which I understand people want to start defining things. But I got a couple of questions from Europe and I was like, okay, you guys, the drugs still haven't come yet. And we're talking about futility rule. But that slide was important because, and again, I don't want to sound like it's like I'm just pushing for longer duration and stuff like that. But still, it's a chronic disease. We have been like waiting for such a long time to have a treatment. People have it for years. And now we want to talk about stopping treatment immediately after 1 year response. And I'm not going to go into cost and any of that. This is a different topic for cost of effective analysis and ICER and all that. But you're right, Jörn, beyond the 1 year, we saw that the fibers can continue to improve at year 2 and year 3 on those that completed them. But also what I asked them to put on that presentation is, Samer Gawrieh's present data from Indiana University and NASCAR, and they showed that if you drop your stiffness to less than 10 kPa in the NASCAR, and it did correlate with 75% reduction in clinical liver events. And interestingly, Resmetirom, for those that completed year 2 and 3, they were tiny bit above 10, and then they dropped to less than 10 in year 2 and 3, suggesting, and we'll see the outcome data, that you're even moving away from outcomes, and you hopefully with continuation treatment, when you see more outcome positive direction.
Roger Green.
So, Mazen, that's fascinating. I keep thinking of other studies, say the bariatric study, where they looked at 5 years and they were still seeing improvements in fibrosis progression 5 years out. So the story might not even be 3 years long. It might turn out to be longer than that. But I think that's a promising trend and aligns with a couple of other things we know. That's great.
And then to me, the important story is, we have the NITs. We know about their prognostic value by now. There's a great presentation from the VCTE prognosis study group, also recapitulating the data that Mazen just mentioned regarding to outcomes, depending whether you change your stiffness, starting high, going low, or low and going high. So I think this is really how we're going to use the NITs. And again, Naim and Mazen can comment on how they use it in their clinic already today, but that's important information.
Right, and the 30% rule is shaping more. The VCTE more than 30% is shaping more and more, and it's becoming more a rule of thumb. Go ahead, Naim. Sorry to interrupt you.
Naim Alkhouri.
No, I think one of the key messages, as you guys talked about, is that decrease in liver stiffness was sustained at 2 years, at 3 years. So that speaks that we're not losing target engagement, that efficacy is going beyond the 1 year interim analysis that we saw in Maestro NASH. And to stick with the Resmetirom data, of course, we've seen other studies showing very promising results, and we will discuss in details. But most of the data that you're seeing is typically modified intent to treat or completer analysis. But the right way to do it is really the intent to treat. So if someone didn't have a repeat liver biopsy, they should count as non-responders. And this is what we have in the Maestro NASH. And this is what people talk about when they discuss Resmetirom. They talk about the fact that the delta on NASH resolution was around 20%, and the number needed to treat is 5 patients to achieve NASH resolution. And the fact that the delta on fibrosis was around 10-11%, and you need to treat 10 patients to achieve fibrosis regression by 1 stage. But I feel like this is the analysis done properly. If you look at a completer analysis with Resmetirom, the delta on NASH resolution is around 30%, not 20, which means you need to treat only 3 patients to achieve NASH resolution. If you look at the delta on fibrosis, again, completer analysis, people that had 2 biopsies, the delta is close to 20%. And this is all in the supplementary material of the Maestro NASH. So that means the number needed to treat on fibrosis is 5. You can argue, yes, in phase 3 trials, you have to do the intent to treat, you can do completer analysis. That's fair, but I just want to bring this up when we start talking about other mechanisms of actions and other trials. If you want to compare apples to apples, this is what you need to think about. And this is the barrier that you have now since Resmetirom is on the market, because everything is looking too good in phase 2, but the way they're looking at the data is really a modified intent to treat.
Okay, listen, we could discuss Resmetirom for hours. I don't want to do that. Madrigal is the sponsor of this episode, and consistent with surfing mass journalistic rules, we should keep to a short, objective conversation, then move on to other drugs.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of the conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, Frank Taka and Luca Valenti from the EASD, EASL, EASO combination group will be joining us to discuss the updated clinical practice guidelines for Mazen. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.